That's good.
Yeah,
All
thanks.
right, guys, welcome to Two Docs, One Mic. This is our episode number three. I'm Adil, and this is Humayun. How's it going, man? How's your week been?
Hey guys, yeah, doing good, man. Excited to be recording this again. It's been fun. This podcasting thing is new but exciting. We're having a good time. Maybe we just like our podcast and no one else listens, but that's what we're doing. We're just having fun here.
Yeah, audience of two. This is just us
Audience.
two.
Yeah, but we're building our audience. I think it's good. I've seen some new follows on our social media accounts, so it's been good. All of a sudden I checked the other day and we just had 8 new followers, and I'm like, wait, we're not even marketing much. But it's
Yeah, it's
exciting.
crazy, crazy how stuff gets out there.
Yeah. How was your week?
Week's been good, man. It's just been really busy. Just a lot of surgeries, which is good. Sometimes it feels a little too busy. When you're just working a lot and, cases come into clinic, patients have bad injuries, fractures. You just got to get those cases in. You can't really let them wait and push them for a while. And so you just add them onto an already busy schedule and it just leads to late nights. So I've had quite a few late nights in the last week. I did 22 surgeries last week, which really was exhausting. So far this week has been a little slower, which is nice. It's a good little break. What about
Yeah.
yourself?
Yeah, man, surprisingly it's been busy. It's fun when it's busy. You see your business growing. I'm a business owner, so I see it in that way too because it's something that I remember the days when I was not busy. Whenever I get too busy, I get stressed out. I think of the days 3 years ago when I started the practice and I had one patient. And I remember my first one of the Fridays I had my echo tech came in. I was like, "Hey man, sorry, I don't have any echoes for you today to do." Just had one or two patients, and that was like that for a while, just three, four, five patients a day. And now I'm just like, oh, it's too many, which is the testament to um, and working hard in your business, and but also Houston being a place of need for cardiology. I mean, I was able to build a practice in 3 years, which is there's a lot of need for cardiologists.
Yeah, no kidding, man. No, it's awesome. I mean, it makes you think, when we like back to when we were in training, and you're so busy learning and just trying to absorb everything. Learn the surgical skills, get better at everything. You make mistakes, you harp on them, you think about them. You want to impress whoever your attendings are. You also want to keep growing and then keep your sanity while you're in there. You don't really think as much, at least I didn't, directly when I was going through training about how actually practice would be. You're kind of like so in your own head about it in that moment. Just one rotation to the next, one surgery to the next, one call shift to the next. You kind of don't take a step back and think like, okay, how am I going to actually grow and market this? You're just like so focused on the day-to-day work.
Yeah, and, in residency, you start residency as an intern year, and I think at that point you're so overwhelmed. We were talking about med school, our last med school in college, and our last episode. But in residency, intern year is just crazy because you're not a doctor yet, and I've said that to many people before. Graduating medical school doesn't mean you're a doctor. You don't know anything. Um, you know, I can put on a medical school graduate, and maybe they can recognize a few things, but they don't know how to treat a patient completely. I mean, they're very new, and interns are just like that. I remember my first day when I was there, and I was asking my senior, can I order Tylenol on this patient? It's over-the-counter medication. I mean, but I still was hesitant about giving that medication to a patient. The way I don't know how it is different. You did a surgical residency, I did a medicine residency, and they're very different in some ways, but in some ways they're very similar. In medicine, we had teams. We had a usually an upper level, which was maybe a second year or third year, maybe just 1 year ahead of us, and there's two or three interns, and that upper level was running the show. The two or three interns would be kind of doing a lot of the work, a lot of the note taking, a lot of the note writing, seeing the patients early in the morning. But it was amazing that you'd look up to this upper level because you thought they knew everything. They've gone through the intern year, whereas now looking back, they were just second and third years. They were unsure too. You know, and intern year, you're just so focused. All you have to do is write the notes. You don't make any decisions. Yeah, you make day-to-day decisions. Here, you know, maybe, can I give potassium to this patient, or can I give Tylenol? But you ask everything, you know, at your upper level. And I think I was lucky to have really good ones. One of my first upper levels ended up being one of my really good friends. We ended up doing cardiology fellowship together.
Well, that's awesome.
You know, we ended up being in the same program eventually down the line. But you know, they teach you the most. You learn the most from your co-residents and the people leading the team. Uh, you know, would be your biggest teachers, because sometimes, you know, let's be real. You know, there are good attendings, and then there's not so good attendings, and there's attendings you have to manage as a resident. You know, was that weird to you? You know, and it might be different for you, but I came across some attendings where they were more in the way than, you know, and these were board certified physicians that were there, but they would just cause so much more stress and problems, and their treatment plans would be all over the place, where the residents were kind of managing these attendings sometimes. I don't know if you came across some of that.
Yeah, I mean, it's almost like, especially like in a surgical residency, it really depended on, like, some of the attendings. They would be very, very hands off to the point that they would almost be disinterested. And you would just be worried, like, am I doing the right thing? Like, I have no clue. Yes, the attending, sometimes they don't respond, they don't answer their phone. They're just totally out of the mix, right? And you and the team, right? As you're talking about the upper levels, you really, really rely when you're a junior resident on your senior residents, or even if there's fellows on the service, like, hey, this patient has this injury, they come in with a bad fracture, like, does this need to go to the OR right now? Can we do this in the morning? Can we post them for when do we do this case? What implants do we need, right? That's a huge factor, especially when you're a junior resident. You don't really have the context and understanding of real surgery because you haven't done it. You're not the one doing the surgery, you're not making those decisions. A lot of times you're kind of just like an H&P taking machine. I mean, you're just moving from one to the next, and teeing everything up. And now you have to make a decision. It's like 1 in the morning, a patient comes into the trauma bay, and it's like, I don't know what exact implant this patient needs to fix their femur fracture, but I know they need to go to the OR. Do I wake someone up in the middle of the night right now just to ask them, do they need a plate and screws? Do they need a rod that goes inside the bone? Do they need both? Like, you have no idea. I mean,
That was a big decision you had to make in training, if to call or not to call.
a huge
You
decision.
know,
Yeah, I mean, a
it's
game
it's
changer.
a game changer, because you could, you know, you could call for just some minor things, and if you keep calling for something things, your reputation gets as the person who just is not very competent. Maybe, you know, maybe in your own mind, or, you know, but people do get a bias where, oh man, this intern, he just calls for everything. Whereas if you don't call enough and don't call at the right times, you can get in serious trouble, because then you know, your attending will not be very happy. They wanted to know about something crucial, that's their license is on the line.
Yeah,
And
I
it's
mean,
important.
towing that line was really tough because, kind of like you're saying, it's almost a negative stigma. Like, it's almost like a sense you have this unease when you're typing that text or about to make that phone call. You're like, oh man, they're gonna chew me out. They're gonna think I'm like a wuss. I can't handle it, or I don't know my stuff. Like, I have to like wake someone up for this. It's yeah, it's just weird. I mean, that whole part of training is, and I think it's gotten better for sure. Like, the culture across the board in residency has improved in that there's not, like, it's not a sense of weakness as much as it used to be. I mean, in the past, you hear stories from your attendings when they were in training themselves that, I mean, it was unheard of that they would call someone for help. It was like, that means you couldn't handle it yourself, which that has changed, right? Because patients suffer when you just kind of try to make it up on your own and hope it works.
Yeah, and that's when it's important to, you know, as an intern, it's always, you're not the one that's getting in trouble much, because you always have upper level resident to kind of ask, go to, and look to questions to. And if the upper level resident doesn't know answer, they can always kind of go to the fellow. So there's this hierarchy that's built into academic medicine that allows you to kind of have a little bit of responsibility, but the consequences be a little bit more cushioned out by these other trainees that are above you in the hierarchy. And in the end, here's the thing, if you call someone, and even if it was not very important, you told your attending who would have an answer for you, and it's about someone's life and someone's health, so that's important. But it was hard because there are some very good attendings that teach you a lot, and it's always good to call them, and those are the ones you remember, those the ones that were available for you, and you always think you want to emulate that when you grow up, and there's always good role models throughout training. But now looking back, some of the things that I used to think were a big deal, and I need to let someone know, I need to do something about, maybe it was not that big of a deal. And it's the attending, sometimes that, and it's some the things that I used to worry about as a resident, as an intern, like certain medications, certain amount of blood pressure, certain fevers. As an attending, I'm just like, yeah, that's okay. They'll be fine. This is something just we just have to wait and see and what happens. And that's the mentality of most of the attendings. And they as now as an attending, I I can be sympathetic to the fact that they maybe weren't always as involved, or because it was a test as well for us to kind of be able to manage it, because they know it's not that big of a deal.
Yeah, they've seen it, right? I mean, they've lived it. At some point, it's a lot of it is pattern recognition. You see stuff enough, similar enough stuff, and you just kind of understand that, okay, this clinical picture I've seen many, many times. This patient will be fine. There's nothing urgent or emergent that needs to happen. Whereas conversely, a little subtle difference, you can be like, oh my gosh, that really needs to go back now. Like that patient is on the cusp of crashing. So I think that, when you're early on, you just don't have that. You just haven't had enough reps. You don't have the volume of experience from seeing enough patients. Um, and it's interesting when we would talk amongst each other during residency, like orthopedic residency was 5 years, and we would always ask each other, like, at what point do you really feel like you're pretty confident that you can handle it, you understand basically most of the patients that come in, you have a good handle on what's going on. Not necessarily meaning we could execute every surgery, but at least diagnose the patient correctly, get the appropriate workup, the indications, what surgery needs to be done, and the basic steps and all of that. And it's usually like third or fourth year. I mean, it's well beyond the midpoint of residency until you really feel like you're solid and you have a good footing underneath you and you have enough of a foundation. Where you can handle everything, at least the initial management of it.
Yeah, definitely. I mean, it's a process, right? I think the process is not perfect, but I think it's designed pretty well to the way it goes. I was talking about attending, and then some of the attendings that you worked with that were way too involved and were micromanaging, and that was not good for our training either. So I can appreciate some attendings that gave the right amount of space, the right amount of autonomy, versus someone who would constantly text, "Hey, what's going on with this? I checked the blood pressure; it's still high. What are you doing about that?" We had attendings like that that would constantly micromanage, and that was not a good thing for training either, because the trainees need to know when to be able to make those decisions, on their own. In terms of medicine residency, towards the end of second year and beginning of third year is when you start feeling like, okay, you got this, you can take care of this. Because going through that second year of internal medicine residency is the biggest year for your growth, because that's the year you get a lot of independence. You have a team below you, medical students, interns, maybe some other health affiliated students, and you're running a team. You're the leader of the team. You're making decisions, and your next point of contact a lot of time is attending. So that year of growth is critical, and by third year you feel like, okay, now I got most of it. You are much more lax, you're much more ready, and third year is usually a fun year because you're just kind of fixing the fine tuning your skills, and then you get to fellowship, man, and then that's like, whoa, what just happened? I thought I knew everything. I thought I knew medicine. I thought I could handle this, but I became a first year cardiology fellow, and oh my God, this is stressful because now the whole resident team and other attendings are looking to you for answers, and you have to. And cardiology is pretty critical for the sense that there could be minute to minute changes. I mean, people could be crashing, and you have to act and make the right decisions. And the decisions you make on spot can really have an effect. And sometimes you don't have time to wait for the attending. Sometimes you have to do something right there and then to fix things.
Yeah, the responsibility really jumps up, huh?
Yeah, it's crazy. There's you're one fellow, as a fellow, you're covering the whole hospital sometimes. All of one big, huge academic hospital. The ER's calling you. The internal medicine attendings are calling you. The hospitalist from the hospital are calling you. You're getting all these consults. You're going to the ER and this guy with a heart rate of 25, and you're bedside doing a transvenous pacemaker at the same time and calling the cath lab. While someone else is crashing upstairs, the residents are calling you, hey, this patient is, their blood pressure is tanking, they're going to cardiogenic shock. So there's a lot of things you're juggling at the same time, and you kind of learn those skills. But the first year of fellowship, man, that's I think one of the most stressful times I had. But it was fun. I mean, because it's the I think in medicine residency or internal medicine per se, the more you grow, the less you're actively doing and more you're managing and making decisions. So I wasn't writing too many notes. I wasn't sitting in front of the computer and just writing HNPs on HNPs, but I was making the decisions. Sometimes those are the hardest things to do.
Yeah, and that's what's interesting. Like in from the surgical training side, the first couple of years, especially second year, is super busy, and that's kind of the norm across the country in orthopedic training. I did my residency in Tampa, and basically second year, I mean, you're loaded up on call. You're taking so much night call, 24-hour shifts. Um, and it's just kind of you. You're the one who's holding the pager, your first call. You're answering all the trauma alerts. You're in the ER. You're reducing fractures, putting on splints, repairing lacerations, repairing tendons in the ER, getting people teed up and ready for the OR, managing the floor. You're doing it all, and we usually had a census, like a 50, 60 patient inpatient census that we would follow. Um, and you're getting calls about all of them. And so second year was like, I mean, it's just a blur. You barely even remember that year of your life. Um, I remember at one point, um, you have your personal pager, you have the service pager, and you have a separate pager, legitimate, real beepers, like very old school, for the trauma alert. So you have three on there. And you have your scrubs on, and scrubs are loose. They're always little loose fitting. And I was just rushing back and forth, consult after consult. And I had to go to the bathroom so bad. I had to just, I mean, I was like, oh my gosh, I think my bladder's going to explode. And they're all on your waistband of your scrubs. And I wasn't even thinking. I was just rushing. I was so tired, you're sleep deprived. And I got in front of the toilet to go, and I forgot that all of the pagers were still on my waistband.
Oh
As soon as
God.
I undid the drawstring, all three of them fell into the toilet. And I was just like, oh my gosh. And my first thought wasn't even like, oh my gosh, these are all going to be dirty now. My first thought was, oh my gosh, there's pages that were unanswered. I'm going to get written up for this.
Yeah.
Like, and I was just like, oh my god.
There's
Fished
so
them out of
many.
there, cleaned them off, and just kept going. I mean, you just got to keep going. It was crazy. But like that year, that second year was just like a whirlwind. But your skills get up so much. I mean, in that one year, probably saw, I'm not kidding, like maybe 1,200, 1,500 patients, like tons of consults. Um, you just get so many repetitions in. But then, how you're talking about as you progress further into residency, you kind of your role and the type of work you do changes. Is similarly like you start taking a lot less call as you become a senior resident, a lot less primary calls. So you're not the one responding immediately to every ER page, every consult, every trauma alert, but you're on backup. So it's a lot more decision making role and guiding role and teaching role for the residents who are now on the trenches. And then also doing the surgeries. Like now it's a much bigger role and responsibility. You better be ready to go in and do the cases and take care of these patients and get them into the OR, get them on the table, fix them, get them off the table. So and that's a totally different skill set. Really, in the first couple of years of residency, you're not doing a lot of surgery, or if you're in the OR, you're just doing little amounts of it. Every now and then you'll get to do more, but really the bulk of the operating comes in third, and especially fourth and fifth year, and that's where every single case. I mean, that's a huge, huge opportunity. That this is your time, whether it sounds good or bad, this is your time to practice. This is your time to really learn how to do surgery because after this, you're on your own. You better be ready to go because if you do not come out of residency confident and well trained, you're not going to be up to par when you're an attending. And there's no backup. There's no one to call on and be like, hey, can you come bail me out? I can't get this fracture reduced, or the joint replacement isn't balanced, it's dislocating. Like, you better know how to do it. So the decisions and the roles change a lot, and your responsibility just changes a lot. It's not necessarily that it's more or less, it's just very different.
Yeah. It's that's so true, and I think medical training is designed to be kind of like that, where it's a slow transition from a lot more doing work, seeing consult, writing notes, and then slowly going forward, and then being the person making the decision, leading a team, doing those procedures and surgeries that are much more high stake. You do a lot more high volume, low stakes work in the beginning, but then as you grow on, you're doing less volume but high stakes stuff. And that's it's a beauty of the way the training is kind of been set up over time, over years and over time. But it's you realize that, I mean, as a first year fellow in cardiology, you have to take those consults, you have to see those things, so you get comfortable by your second and third year, because you're now teaching a first year. I mean, you have to be in the cath lab. In our cath lab, it was funny, I never understood it. It was kind of annoying to we'd have to get early in the morning, and we'd have to see all the cases that are set for that day, and then our other fellows from other services would be texting us, hey, we need to add this cath or right heart cath or this procedure. Oh, and we'd be like, well, why you keep adding stuff? Like, is this truly necessary? And then you and your co-fellow, we had to like sit there and write the whole board, and and then be ready at like 8 a.m. to present to the attendings of what cases are there that day and why are we doing it. And a lot of times we'd be like, hey, I don't know why our fellow, co-fellow is adding on this case, and they'd be like, yeah, this is, it kind of, you just go back and forth, like, it's truly necessary. I mean, they could do this first instead, or do that, and you learn a lot of decision making in that, because you're kind of triaging, as well, if this is truly necessary, if this is not necessary. But writing the board, knowing your patients well, knowing details about them, because sometimes, now as an attending, I do hard cats, and I just go in, I know the patient in the back of my head, I know why I'm doing it. But when you're a fellow, you had to present it to the attendings that I'm sure had a little bit of knowledge about why the case is happening, but I think more of it was for your training and for you to be able to know why you're doing a case you're about to do. Because once you are on your own, you have to explain it to not just your attending, but you have to explain it if things go wrong, to the medical board sometimes, or to the hospital administration, or to the quality control people in the hospital, why you did this case and why you think the complication happened. So it's just training for this gruesome career that we have, in the sense that there's a lot of checkpoints throughout the way through the training, which is good. I think it's necessary.
Oh, for sure. I mean, it's the whole sense of graduated responsibility, right? And it's kind of like guilds back in the day in like medieval Europe, where you start as an apprentice and you slowly work your way up until you become the blacksmith. A lot of steps along the way, a lot of check marks, a lot of checkpoints to hit, and improving your skill slowly but surely. And a lot of it is just forced time. I mean, it just takes time to practice and hone a craft. Nothing
I
happens
mean,
easy.
yeah, I have nightmares, man. And like sometimes, I just remember those days. The first year, we'd have this call that would start at like 5 p.m. on a Friday, and it would just you would be on call Friday night, new admissions, residents calling you, new residents be like, hey, I have an admission, I have this. You're the fellow coming on. You have no idea what's been going on this whole week. They're texting you, hey, this patient might be crashing. Next Saturday morning, you go in to kind of round on all the patients and are taking new admissions. You still are supposed to learn the whole service, and your pager just keeps ringing. ER consults. But now, going through that weekend that happened every couple of. Now the weekend just seems like a breeze to me as attending. I mean, it just, I get a page, and I know what to do, how to deal with it. I let the hospital team triage it, and I see them in the morning. If something needs to be addressed right away, right then, I can make those decisions. But going through that and getting bombarded by pages, bombarded by other residents and other services, just taught you how to deal with it and triage it. I think that a lot of time, there's a lot of programs like towards my third year, they were starting to have more protections, and okay, the fellow can only work this many hours, and they have to go home otherwise, and they cannot be contacted. A new fellow has to come in, whatnot. And sometimes that's not how real life is. When I'm on call all the time. And, if you're just creating this shift work mindset, that's not good for how real life ends up being, because real life is not shift work. My patient panel, as it grows for all my patients, you know, I have over 1,000 patients. I'm in charge of their cardiac health, and throughout the week something could happen. They might call and say, "Hey, my leg is swelling up. Like, what does Dr. Naqvi recommend?" And the nurses reach out to me, and now I've developed this skill set of remembering the patient, knowing the big picture about them, what we're doing, and kind of making suggestions on the go sometimes. And if I need to look into their chart a little bit more, I'm able to do that. But a lot of times, I'm surprised at how I can remember a lot of my patients, because I can make those decisions for them, give them answer right away, right then. But that came because I went through that process. Because in the beginning, when I started the fellowship, I couldn't keep 10 patients straight in my head when I'd be juggling a list of patients, and I wouldn't know which patient is which. I would get confused. But now I can have a list of thousands of patients in my head, and kind of know what to do when there's a question about them.
Yeah, I mean, it certainly teaches you a totally different way to think and manage and compartmentalize. And it builds a bit of a toughness, right? Like anytime you go through something that's grueling, it may suck in the moment, but we all look fondly on it in the past, and it kind of makes you who you are, and it lets you handle situations. That's why it doesn't seem really like a big deal when something happens now. Residents text you, they're on call at the trauma center, and hey, this guy came in, this car accident happened, this motorcycle car accident, auto versus pedestrian injury. You're like, okay, let's just fix them up. Just put them on the board. It's just, but when I was in their shoes as an intern many moons ago, it's like that novelty of it, right? That excitement. A little bit of that excitement just goes away once you see things that often. It's like a little bit of desensitization, which it's not that it dehumanizes you or the patients, but I think some of that is necessary to be able to think with a level head rather than get caught up in the moment, and the excitement of the situation around you. So I think that's a big factor, and it's important. And I also think that's why, with the duty hour limits and restrictions on training, which currently, it sits at 80 hours is the cap, potentially restricting more than that, which there's talk of, I think is dangerous, because you're just going to have to lengthen training, because there is just a certain amount of stuff you have to see. There's a certain amount of patterns you have to see again and again. There's a certain amount of repetitions you need to have for you to be safe and consistent and reliable as a physician down the road, to really take care of human beings unsupervised on your own. And I saw that a lot when I was abroad. I did quite a bit of my training, whether elective or my second fellowship, outside of the US. I did some of my training in France, in Annecy, some in Norway, and then my second fellowship was in Australia. And the training environment is vastly different outside of the US. And I'm not just saying it because I am American and trained mostly here. I think the training is better here, mainly because of how much work there is. That the residents here across the board, they work like crazy, really long hours, and they work hard. In a lot of places in Europe, like the UK, there's like a 40-hour limit. I mean, it's like a standard job. You just cannot get the same amount of repetitions and volume. You're not going to see the same number of stuff in the same amount of time. And that's why people train for so much longer outside the US. I mean, so many of the residents when I was in Australia, they were in their early 40s, which is crazy. Like, they just have to train for so much longer to get the same amount of hands-on experience.
Yeah. It's about the repetition as well, and being able to see so many different things, but it's also about being able to make those decisions when you're just dead tired. Learning how to make those decisions, because life is, you will be tired, you will be overworked. I mean, maybe it's the nature of our healthcare system where doctors are burnt out and overworked, and our system is preparing us for that. But I think some of it is also being able to make the decision under. Sometimes you have a 6-hour case or 8-hour case, and you have to keep making the right decision for the patient. And then maybe after, or on a day you might have a 4-hour case, and after that you have an afternoon full of clinic, and you're exhausted, and you have to keep making decisions. The other day, I had a on Monday, I had a full clinic started in the morning. I saw maybe 14 to 15 patients in the morning in 3 hours. Then at 12 to 1, right as my clinic ended, I like said bye to my last patient. I head straight to the cath lab, and I had a case from 12 to 1. No time for lunch, no time for anything else. Just went straight to the cath lab, did the case from 12 to 1. Ended up being a more complicated finding. Had to talk to patients a little bit in more detail about their, they're getting needing a surgery and a lot more, uh, extensive workup after that. So and then I was kind of running late for my 1:30 p.m. clinic start, and then I had to rush back and see another good 15 15 or so patients in the afternoon time right after that, which is back to back. So it's like there's no breaks, or sometimes, and you have to, you see 30 patients in the day, plus you see, you do a procedure in the morning, in the afternoon you round on your hospital patients. And there's no way you could do that kind of work if you hadn't gone through the grueling training that you went through in internal medicine, or surgery training or fellowship. It's part of it. I mean, there's no way I could have done that. I remember when I started fellowship, I would have 7 patients in the VA clinic for the whole day, and I would be complaining because that's too many. you know
Yeah, man. I mean, like going through grueling stuff like that grit, it's the same thing like with athletics, right? I mean, practice has to be harder than the game. I mean, if you don't practice to the max, you're going to get destroyed when it comes to an actual competition, right? I mean, that's such a common thing. Same thing with like the military. You know what I mean? Like the grueling training and the trials you put yourself through. There's a reason why training is so hard, why boot camp is so hard, why the selection pressure is so high for like elite special forces, as an example. And I'm not comparing myself to that. I would get immediately kicked out before I even finish the application. But I'm just saying, like that idea of going through a very grueling training process, I think it's really important, and I think it's critical whenever you're in a situation where you are going to be responsible for other human life, right? I mean that's what it is, and so I think it's important, and I think putting too many safeguards in place, like too much time off, too much restriction of the hours, too many post call days or whatever. Yeah, there needs to be a balance, but I think if you strike too much of a balance towards making training easy, you sacrifice a lot in an entire generation of trainees who are going to go out into practice, that they're not going to be trained as well as the generation before. It doesn't have to be malignant, it doesn't have to be mean spirited, but it just needs to be time based. It needs to have some amount of baseline number of reps, number of volumes, so that you can have great training and be confident in your
yeah.
training.
And I don't know how it is in surgery, but in medicine and cardiology, there are programs that are very high clinical program where you see a lot of volumes, high stress, seeing a bunch of patients, doing a lot of work clinically. And then there's some programs that are more academically inclined where you do have a lot less workload, less procedure load. You're more academically inclined. You're maybe publishing a little bit more. But there's a vast difference in the trainees that come out of these programs. I mean, one of them, one program produces more academically inclined physicians that are more, focused on research, and yeah, they have a clinical side, but their main focus is research. And then there's programs that produce clinicians that are very clinically strong, but academically they just have never learned how to promote and advance research in that sense. And there's a role for both, right? There's a role for each, and both types of physicians are needed. We need research, we need advancement of medicine, we need those people to have labs and do research and maybe their clinical workload is less compared to someone like me who went to a clinically heavy program, and now in a more clinically heavy setting, even though I do research, it's more clinical, industry sponsored research rather than research that requires a lot more academic grit. So there are programs. So you have a choice as a trainee. What kind of lifestyle you want, what kind of training you want, and maybe some programs. If you value your mental health a little bit more and lifestyle, maybe a program where there's a lot more focus on research and more academic heavy programs rather than clinically heavy programs. There's always choices, right? Where you can go and interview, but in the end, the match decides.
It makes the decision for you. Yeah, you just rank the list. I mean, do you think like one is better than the other?
I mean, it
Like a
depends on what you
so-called
care
white
about.
collar versus blue collar, kind of that distinction of, very white collar academic country club style versus blue collar grueling hard work, not really as focused on pumping out a bunch of papers and publications.
I mean, there's a need for both, right? I mean, the I do have a little bit of problem with the new age academia, in the sense that there's a lot more publishing for the sake of publishing rather than publishing for the sake of knowledge. A lot of people just want to pump out papers and volume of papers rather than the quality of papers, and that's going on as well. And some people just truly enjoy that, but we do need that. I mean, sometimes you publish 20 papers, and out of them, one is can be a breakthrough, right? Science is never efficient. You have to do a lot of inefficient work to get one breakthrough, and that breakthrough can save millions of lives. So, I don't think one is better than the other. I honestly, as a trainee going in, or you have to envision what your life is going to be like, what kind of medicine you want to practice. If you want to be in a clinical setting, you want to be in a private practice setting where you're seeing patients and kind of interacting, doing more clinical stuff. Yeah, and you want a procedure heavy uh, play where you want to have like very high skills in doing either surgeries, or you want to have high skills in doing hard cats or PCIs, which is coronary interventions. Then you go to a clinically heavy program. But if your clinical goals are to maybe be assistant professor or associate professor at a academic institution, and maybe have a research lab, also see some patients in your clinic, which is more of a niche clinic sometimes. If that's your goal, maybe go to a more academic program, right? Which What do you think about that? I mean, I guess you did your residency at Baylor, but I don't know about your other programs.
No, I did my med school at Baylor, but
Baylor, okay.
residency was in Tampa. I mean, like this is my bias. Obviously, some people will think differently, but I think, especially if you're doing a procedural field like surgery, and even non-surgical fields that are very procedure heavy, like some cardiology practices, GI, things like that. Um, you train one time. You can always do research. You can always write papers, but your training experience and opportunity will not come again. And I genuinely think if you're doing something procedural, a manual skill based thing, which is simply improvement via practice over time, I think it's critical to be in a training program that allows you to do a lot of volume and autonomy to do that too, not just simply watching one of your attendings do the surgery again and again and again. I mean, you have to watch and see how it's done the first handful of times and be guided through it, but you have to have the ability to do it. And that really only happens in these so-called blue-collar programs. I mean, that's simplifying it, right? Every program has a little bit of both, but there are certainly programs, especially those that are associated with very like big county hospitals, trauma centers, often the are places that take care of indigent patients. Those are the centers that just have a very high volume, and volume drives everything. The number of patients you see, the number of cases you do, the variety of cases you do, all of that comes from volume. And I strongly believe that if you are a surgeon or someone who is heavily procedural in your clinical practice, I mean, you have to be good. And you're not going to be good if you haven't done a lot of it. And the only way to do a lot of it is to go to a program that allows you to do that. And so that's my bias, right? But I really think that if you want to be good as a surgeon, you have to be in a place that allows you to practice and get good at surgery.
Yeah, that's very true because I saw it firsthand. In my cardiology fellowship, I had different types of attendings, and I had an attending who had come out of a very clinical heavy program that you just could go to for any procedure. You could go to him, and he was newly out of training, but he could do advanced stuff. I mean, very complex procedures. And then another attending who was just out of a more academic, white collar program, and you could see the difference. You could see the difference. I mean, the time it took for one guy to kind of just do the procedure, how nervous he was during one, his comfort level. You could clearly see the difference in the procedure skills and ability. Maybe academically and clinically, maybe in terms of their knowledge, one person from the so-called white collar program is much more advanced, and they have a lot more. they're more up to date on the new advances and the new therapies, and maybe clinical knowledge wise they're ahead procedurally and how to get through complicated things, and how to in our case fix complex coronary disease. There's definitely a huge bias in the sense that go to a clinically heavy program where you get to do a lot of procedures independently. I mean, in our in our VA cath lab, I mean, we were the fellows were in the case from beginning to end for the most part, and it was
Yeah, you
amazing. I
just
mean,
you ran the show, right?
you ran the show, the kind of training you
Yeah.
got there, and there was attending supervision. I mean, he would be there if something was going down south. He would just quickly scrub in, but for the most part, he just watched, and it was amazing. And you appreciate those kind of training because that gave you confidence. Now, I can go in and know confidently go in knowing in that hey, if something comes through, a problem happens, I'll know what to do with it because that's how I was trained.
No, for sure, man. I mean, I just remember like when I was in residency, um, you have new attendings come in, get hired in the program, and it was very evident when a fresh attending came in, year one or two of practice, that had basically gone to a program that they really didn't do a lot of independent operating. And our program in Tampa, it was a blessing. I mean, it was extremely trauma heavy. We had a lot of a very large catchment area at Tampa General Hospital and in the training program there. And so we did a lot of surgery, and we had a good amount of autonomy, and our attendings really let us operate. I mean, I remember I think I was a fourth year resident, and this new attending came in, and they were doing a knee replacement. By that time in residency, I'd maybe done 150, I don't know, maybe 200 almost knee replacement, like a lot. Like we had a lot of joint replacements. And this attending, he had only learned how to do it using a robot because his robotic guided surgery is becoming a thing. It's becoming very popular, but we did them all freehand. I mean, only a couple of our attendings used the robot to do it. We just learned how to do it the old-fashioned way by measuring, by understanding the balancing of the joint, how tight or loose to make it so it was stable and didn't dislocate, but still had fluid motion, right? To treat the patient appropriately. And so on that day the robot wasn't working. It was the software or something like that. And like the guy couldn't get through the case, like literally couldn't finish the case. And like the nurse who was in the room came out into the hall, because we had a bunch of rooms stacked back and forth that were just orthopedic rooms for joint replacement, for trauma, for spine, for everything. And she came and she found me. She was like, "Hey, um, the Mako robot isn't working. We're kind of stuck. Can you come and help?" And I was like, "What?" I mean, the robot's not working. Just do a knee replacement. She was like, "Yeah, he can't." And I was like, "What?"
Ooh,
It's
yeah,
kind of awkward. Go in there and
yeah,
you have to
contact.
kind of like toe the line a little bit because he was the attending and I was still a trainee. And I was like, "Hey, just wanted to check in. Is everything going okay?" I didn't want to make it known that the nurse came and told me like, "Hey, he needs help." And he just looked at me and was like, "Yeah, the robot's not working. We can't figure it out." And you kind of offer like, "Do you want me to scrub in?" And he was like, "Yeah, sure." And we finished the whole case. It just did the knee replacement like the old-fashioned way, but that's how we were trained to do it.
Yeah.
But that just shows like when you're so reliant on only technology or only the newest thing, and you haven't had enough repetitions or enough experiences like that. I mean, things are gonna break. You need to troubleshoot stuff. And it wasn't just me like that. Like all of our residents, they were trained very well.
Yeah.
And so we were lucky in that sense. But that's why, so experiences like that, um, it really makes you value the training you got and the ability to get your repetitions in.
And the last thing it kind of brings you to is being humble in medicine, because and knowing to ask for help, because there will be times you will be stuck and there's no one higher or lower than you to ask for help. I mean, a lot of times now, I ask for help, the cath lab techs, hey, what do you think, what do you see, because it's important to ask for help, ask for there's some people, I mean, there's some techs in the cath lab that have been doing hard cats since before I was born, and just because I'm the physician and I'm the doctor that's leading the case doesn't mean yeah, medically my knowledge is there and I know, but technically they've done so many cases and they've been doing it throughout the years that they know a lot too. knowing when to ask for help. I mean, your attending agreeing for you to scrub in and kind of let you do the case because he was not comfortable. I mean, that's knowing. Okay, yeah, maybe let's right now let's let our ego go and let's do what's best for the patient. And sometimes it's important to know when to let your ego go. I mean, that's one thing I've learned through years of training is the ego sometimes gets you in the most trouble, and sometimes letting go of your ego and yeah, having the confidence in something in your abilities and what you can do, but then not letting your ego get in the way of when you need help.
But totally. I mean, yeah, you can't try to be a hero because that's how you get into trouble and you get your patient into trouble for sure. And I mean, just like you said, I ask my colleagues for help and assistance and advice all the time, all the time. I mean, sometimes you're just in a really hard case, or you know ahead of time going in, like, hey, I think this is going to be an issue or a problem, and I'm going to either need an extra pair of hands or a different skill set, right? Like I do cases every now and then combined with like vascular surgery, some complex upper extremity case or like a deformity case or something like that, where they are by far better than I am at handling the vessels, the arteries, things like that. I mean, I would be foolish to try to take that on my own. You know, it's there. There's no heroics there. You got to load the boat, and
Yeah,
it's a team sport.
it's a team sport, man, for sure. I mean, we can keep talking about this stuff forever. There's so much to discuss. There's so many things that to come in the future for us to talk about. And not just about medicine, but more many other things. So I'm excited for this podcast to go on, and let's see where it goes. But we'll hopefully meet next week. And
Yeah, yeah. Stay tuned. Episode 3, guys, in the books.
all right, see you
All right,
guys.
man. See ya.